because they are the people who are doing all the work. I'm going to talk about the why, the how, and the future. So let's go back to the UK when I became a senior physician in the early 1990s. And frankly, care was terrible. In fact, colleagues from Germany, who I'm going to talk about, were extremely rude about our care. They said we didn't know how to manage diabetes, type 1 diabetes, and you can see the results on this slide with really bad outcomes of diabetic pregnancy in the UK, recorded over 5 years. And we should, and we weren't as ashamed as we should have been about what was happening. So why didn't this treatment of type 1 diabetes work in the UK in the past? Because the doctors were in charge and they thought they knew better in terms of managing patients that they would often see twice a year. The treatment started with an insulin dose, and they told people with diabetes to fit their lives around it, particularly diet. And I remember at a children's camp, dietitians wasted an hour to make sure that these 6 to 8-year-olds ate their carbohydrate portions. Ridiculous. And it's difficult to believe that people who thought they were intelligent could do that. The doctors and nurses were in charge, and they adjusted the insulin a few times a year. So it was designed to fit a model of acute care, not a long-term illness. And as Dr. Ahmed Iqbal said in the workshop early today, the person who has to do this is the person with diabetes. And not only that, but the treatment is very challenging, giving sub-Q insulin to replace carbohydrate metabolism. And yet, in the early 1980s, Professor Michael Berger and his wife, Professor Ingrid Muhlhauser, had realized what needed to be done when blood glucose monitoring was introduced to the world in the late 70s, early 80s. They realized that it's the person with diabetes who needed the skills, and our job was to provide the training to enable that. Blood glucose monitoring for the first time enabled somebody with diabetes to implement their self-management, and he used an approach called therapeutic education to develop a training program, separating meal and basal insulin, using insulins at the time, which worked pretty well. All insulin, of course, has limitations. And the doses were adjusted on the basis of blood glucose monitoring, particularly pre-meal glucose. And very challenging indeed for people, doctors. They advocated a totally flexible diet with no forbidden foods, completely different from the situation in the UK. He was so rude about diabetes care in Britain that I and a few of my colleagues went to Dusseldorf to see, and we were amazed. This was a fantastic course. The people who participated would wait months to do it. And the German colleagues translated from German their program into English, and we developed something called DAPHNE, which we call Dose Adjustment for Normal Eating. 38 hours of teaching by specialty nurses and dietitians, and that was a huge advantage for us that we had those healthcare professionals with us, teaching the training in groups 6 to 8 over 5 days. It was a skills-based program in flexible intensive insulin therapy with background insulin given at the time twice daily and separated, as I've said. And people were taught to count carbs. Gosh, this is moving without me touching it, which is very impressive. Anyway, so we did a trial funded by Diabetes UK as a project grant. They were pretty dubious whether it would work. We got 141 participants around three areas of the country: Sheffield, North Tyneside near Newcastle, and Kings. And we provided the training. And here you can see the results. they're modest results. This is HbA1c starting at 9%, showing how poorly glucose levels were. And you can see that the people who did the training first, the orange immediate Daphne, they had an improvement, drifted back again, and the people who went onto it after 6 months as a control